Coming to the clinical history of the case, it's a 60-year-old male with chronic hypertension, diabetes, and recently recovered from COVID. And his presentation was ACS NSTEMI and TROP positive. It was the index event. And ECG was showing mild ST depression in inferior leads and RWM in RC territory. His creatinine was 1.02 with eGFR of 82. And this was the index angiogram. And it's showing left system, showing Ostial LED total occlusion. And you can see retrogradely LED is filling from the OM collaterals. And this was the RCA, which was the culprit vessel and the index event. It was subtotal occlusion. So the primary PCI was done to the RCA. And the time of index event, LED wiring was just attempted, but it was went into subintimal space, so it was abandoned. And this was the anatomical. Generally, we in our institute prefer to do, and for planning the case of a CTO. So you can see this is a RCS stent, and this is the LED, and this is the Ostial LED total occlusion, and this is the CTO segment. It's a long segment, and proximal cam look ambiguous with total CTO length of more than 20 mm, and there was no much significant calcium with angle of less than 45, and distal lab was very clear. And it was a retrial lesion, so total JCTO score comes to be 3, so it's a complex CTO. And in this anatomicogram, we can clearly see there are septal collaterals from distal RCA filling the LAD. And also, you can see epicardial collaterals from the LCX, which is filling the diagonal. And you can see these two diagonals are joining the CTO segment. We are not able to see the origin of both the diagonals. And this was our wiring strategy. It's a normal cartoon showing the wiring strategy. So antegrade, if we try this case with antegrade wiring without Ivus, what are the possibilities? So if you wire the ostial proximal cap, and if you, without doing Ivus, if you enter the LAD, possibly you can end up in a subintimal space, and you may cause intramural hematoma, which can compromise the LCX ostium. And if you do go directly with retrograde and without Ivus guidance, what is the possible things to happen? Same thing, if you go retrogradely, you may enter subintimal space, and if you balloon it, again, you can compromise LCX ostium. So our wiring strategy was to take an Ivus guided entry and do reverse cut. That was our plan before entering the case. So as we put the Ivus from the LCX to live Ivus guided entry was the plan. And this was the area of our interest. You can see there are 2 to 3 branches. We were with ambiguous cap. So identify the LAD ostium and puncture the cap was the idea. So this was a second staged LAD CTO procedure. And we took a dual LAD injection. So you can see beautiful collaterals into good interference from the distal RCA to the LAD. You can see the LAD is filling retrogradely. Till the mid LAD. And this was Ivus guided cam puncture with the slipstream technique generally we use. So here the Ivus catheter is parked in the LCX, and we try with a microcatheter in the LAD ostium. We'll try to puncture, identify the cap through the Ivus. So how do we identify the proximal cap? So this was the before this is a LCX, and as we come proximally, we will able to see the LAD cap. And here is the Ivus guided entry, which first time when we tried went into subintimal space. You can see clearly this was the area where you can see the wire went into subintimal space. You can see here. and this was done with Gaia 2. And since we are not getting good, we want better stiffness and better tip load, we went on to escalation to Hornet 10. So with the Hornet 10, we were able to enter in the caps. You can see clearly it was the center of the proximal, the LED ostium, you can see. This was a proper entry without entry into subintimal space. And this was images, serial images showing the Hornet entry from distal to proximal. You can locate here. So after this, we pull back the wire and then the crusade catheter. This is the strip so that the wire is not disturbed and we don't lose the wire in the antegrade. So then we put a trapper to remove the crusade and the LED, and we'll try to over the antegrade wire we'll pass the corsair into LED for better stability. You can see here this was the corsair catheter. And after this we want to de-escalation to Gaia 2 because Hornet is high tip load. There is, if you further progress, there is chance of perforation. So do we de-escalate it to Gaia 2? At this juncture, there was a lot of ambiguity of the antegrade course. So we were not sure where we were going. So that's where we stopped the antegrade progression and took back the retrograde wiring. So here with the JR and guide liner, we tried to localize the best septal, and we did septal surfing through cyan blue. But initial 1 or 2 septals we could not progress. So we could successfully cross to the second septal with cyan. Here you can see it is going towards the LED and it's entering the LED and at the level of diagonal. And retrogradely we advance the caravel over the cyan wire. And you can see the tip of the cyan wire is in the distal LED after the CTO segment. So next, the cyan was not progressing. So we have taken fielder XTR as a retrograde wire again because it has better support to puncture the distal cap. We could progress proximally, and after this we have advanced the caravel microcatheter, and this was a small issue. So when we took the microcatheter injection in the LED, we found that it was subintimal and we entered the subintimal space here. So at 90-degree rotational view, we call it as, we checked the position of the wire. So it was at different level, so we were not near. So we wanted to advance the wire so that since the Ivus guided entry antegradely was through the true lumen, we wanted to advance into the LMCA through the ostium. So this was a retrograde wire position, you can see here. We were able to enter, and since the fielder XT was not giving good support, we entered through the Hornet and retried with Gaia 2 and Gaia 3. And we did reverse cut with retrograde wire and 3 mm balloon. And we have confirmed the Ivus through a wire retrograde entry here. You can see here the 2 wires are seen in the entering the LMC. You can see 2 wires through the true lumen. And after this, we have to check the Ivus enter the guide or not. The wire enter the guide or not for the externalization. So we have externalized the wire, and we dilated with the 2.5 mm balloon through the externalized wire. And distal LED, there was some difficulty, so we took a crusade and entered the distal LED by keeping it exactly at the entry of retrograde wire. And this was I was taken after through the another wire which entered the distal LED, and we saw that there was some amount of subintimal septal was in true lumen, and some part of this is the false lumen. So you can see diagonal was opening into the true lumen, and this was a compressed true lumen. So there was some amount of subintimal space here, and you can see LMCA there was subintimal hematoma. So we took a 2.75 38 mm stent from proximal to middle AD, and LMCA we did with 3.5 to 28 mm stent till covering the ostium, because there was LMCA hematoma. We didn't want to we want to cover till the ostium. So later POT was performed with 4.25 mm balloon, but LCX ostium seems to be compromised. You can see here, because that my hematoma might have compromised the LCX ostium. So here we wanted to we wanted to do a tap to preserve the LCX. So we did tap, kissing, and report again with 315 and 3.515 kissing balloon, and report with 4.510. And this was the final result. This was the first initial angio, and this is the final result. So with good distal flow, no much of perforations or no any complications. And coming to the learning from the case, approach to ostial LAD CTO needs special attention to avoid on-table catastrophe. And Ivus guided antegrade cap puncture is essential, which is also acts as antegrade preparation for retrograde. And direct or conventional reverse cart can be used. No extended reverse cart to be performed. And stenting strategy needs to be dynamic and decide based on Ivus appearance of the distal LMC after a reverse cart. And intramural hematoma in LM in Ivus, stenting from LM ostium is a safer strategy, so that to avoid the progression of the hematoma. Thank you so much.